All right, we're back. We have Filip Struyf. Filip, thank you for coming on. Let's have you just give a little bit of a background and intro on yourself, and then we'll dive straight into the topic for today.
Thanks, Chris, for having me. It's great to be here. Anyway, it's Struyf, but it's a difficult name. It's a Belgian name and not that popular outside of Belgium, I think. Um, so yeah, well, I'm a professor at the University of Antwerp, the most beautiful city in Belgium. Try to visit it sometimes. I'm a professor in the Department of Physical Rehabilitation. So it means physical education, physical therapy education, and research. And I've been doing that for about 20 years now. So that means everything it has to do with shoulder assessment or shoulder rehabilitation is my main area of expertise, my main research area. I've done a lot on chronic shoulder pain, rotator cuff related shoulder pain, and doing a little bit on arthroplasty, shoulder arthroplasty, and massive rotator cuff tears. But over the last, let's say, 10 years, my focus has been more and more on the topic of today, on frozen shoulders. So it's yeah, maybe because of its mystery, its connection with so many other levels in our body that makes it so interesting, I think, and so much fun to study that from a physiotherapy point of view. So that's my big focus, I think, now in my research areas: the frozen shoulder and rotator cuff problems. So not really the super athletes, but more like the typical patient you get in your clinic as a physiotherapist. I think that's my main focus, and I'm happy about it. And I combine that work with some a little bit clinical work. It's just a half a day a week, but it's all shoulders, just to keep the contact with the patient and to see all the things I'm telling to my students, to see whether they really work in the practical setting. Yeah.
And the reason we brought you on, Filip, is to talk about frozen shoulder and to dive into the book that you just edited and contributed and published within Elsevier. Within, was it the end of 2023 or at the beginning of this 2024 year?
It's just been published, I think, in the end of January this year. So just 1 month ago, something like that. It's been published, so it's fresh, it's new, and it's really the conjoint work of about 54 frozen shoulder experts worldwide. So it was a big job to get them all together and to make it a fluent book about it. But I think we managed it quite good, and we were able to make some sort of ABC from the frozen shoulder. We're going from assessment to rehab to pharmacological issues to sleep to virtual reality to Parkinson to name it, and it's if it's as long as it's related to frozen shoulder, it's in it, I think. So it's
Yeah,
if you're really into frozen shoulders, I think you can dive into that.
totally. It's a behemoth of a book. It's over 300 plus pages. And like you said, 54 contributors. That's awesome.
Yeah.
So we're going to dive into all things frozen shoulder. Let's start with, can you define what actually is frozen shoulder, Filip?
Yeah, that's a good question to start with, definitely. So, frozen shoulder has quite a history of different names. It's fascinating how this condition has been called everything from periarthrite scapulohumeral, the French surgeon Duplay, to terms like adherent supracromial bursitis, bicipital tenosynovitis, adhesive capsulitis, of course, and then frozen shoulder. And I think the fact that we have such several names for it reflects the fact that it's so complex and that we really can't put the finger on the condition. The exact pathophysiology is really much debate on the exact pathophysiology, and that results in different names. And then also you got people researchers that not only want to name it as from a pathophysiological point of view, but more from a clinical point of view of how does a patient experience that. And that's where frozen shoulder is not really a pathophysiological name, but more like clinical name. It's frozen, it's stiff, and patients like that term a lot. So frozen shoulder, I think, is widely accepted term now. It captures the patient's experience, and it gained approval from scientific societies. So I think we can go with that for now. So yeah, definition. There is a kind of definition and description of frozen shoulder. Mainly, first of all, there has to be a gradual onset. A gradual onset of severe, mostly anterior and deltoid shoulder pain, which is also very prominent at night. These are important things. This gradual thing is very important. You're not perfect, and then the day afterwards you wake up with a frozen shoulder. That's not a frozen shoulder, so it needs to be gradual. And then, of course, it's about the range of motion, the active and passive movement restrictions, notably in the external rotation. That's a typical thing for frozen shoulders. So that's if you would name the hallmark features of a frozen shoulder, is it's some kind of definition we use in research now. It's a loss of range of motion of greater than 25% in at least two movement planes, for instance, elevation or abduction, and exceeding 50% for passive external rotation. 50% loss of external rotation, and that all compared to the unaffected side, to the unaffected shoulder. And this restriction pattern should be there for at least a month and not getting better. So that's some kind of definition we use if you classify your patient as 50% external rotation restriction, 25% in two other movement patterns. It's there for 1 month. It's not getting better. Then you probably have a frozen shoulder. That's more or less a definition. And then, of course, you got some clinical tools, some clinical things to think about when you look at your patient. But from a research point of view, we often use that definition as a rule-in for frozen shoulder. And then, of course, we want to rule out a lot of other things. But basically, it's about gradually over weeks, maybe even over months, and it can take a while before you're sure that it's a frozen shoulder. So, and also these sleep disturbances are very common in the early stages. So it's something we often forget. That's an important thing that differentiates with other typical rotator cuff related shoulder pain, for instance. That's the sleep disturbances. They wake up, they can't sleep at all, and that's also there in rotator cuff related shoulder pain. When they lie on their shoulder, they can say, "Oh, when I turn on my shoulder, I sometimes wake up, but then I turn on my other shoulder and it's okay, I can sleep." But in frozen shoulders, you can lie on your injured side, you can lie on your unaffected side, you'll be awake, and that's typical for frozen shoulders. Yeah.
And is there a known population or age group of individuals that typically present with frozen shoulder?
Yeah, well, we do have some idea about that. And if you fit within a certain age range, and which it mainly peaks around your 50s, so okay, your likelihood is rising from your 40s and decreases from your 60s, but it's really peaking around your 50s. And in some countries they call it a 50-year-old shoulder. So it's typically around that age. But if you're around that age, then actually everyone can get a frozen shoulder. There's not someone who say you're super healthy, you're never going to get a frozen. No, even a super healthy unfortunately can get a frozen shoulder. But we do have some people that are at higher risk than others. Well, this list of people at risk is, to be honest, quite long. There is really a long list of comorbid people that are at higher risk for developing a frozen shoulder. Maybe I can mention a few. For instance, the most important one, the first and probably the most important group, are people suffering from the metabolic issues. Diabetes, both type 1 and type 2, is a very, very common comorbidity. We know that there a usual prevalence figure is like 5% in general population. 5% can develop frozen shoulder, up to 10%. Well, in diabetes, we have percentages going up to 60% that can develop frozen shoulders. So that's massive, of course. That's not a coincidence anymore. So there has to be something related between all these metabolic issues going on and the development of a frozen shoulder. So diabetics, definitely. Hyperlipidemia, also hypercholesterolemia. Also, this typically metabolic people. Obesity is also a predictor for a frozen shoulder. A bit more in women than in men. So let's say 70 up to 30%. So 70% women, 30 men, depending on the study you find. But it's more in women than in men. And then you got other inflammatory diseases like chronic inflammatory arthritis, Dupuytren disease, even neurological issues, people with Parkinson, for instance, Parkinson disease or a stroke, they're at a high risk for developing a frozen shoulder. People with thyroid problems, thyroid dysfunctions, mainly due to the calcitonin, the hormone calcitonin deficiency. It's an interesting pathway. They are at high risk for developing a frozen shoulder. And then we even see people that develop a frozen shoulder after some medications. Medications for HIV, tuberculosis, anti-tumoral drugs. They can all have an impact on development of frozen shoulders. Also, some medical interventions like intravenous infusions or vaccines. We know that from the COVID-19 pandemic, a lot of frozen shoulders developed then. And well, the vaccination was a hypothesis, the immune response on vaccination. But others said no, it's the lifestyle change. They're in a lockdown, they're at home, they don't move that much, and they develop a frozen shoulder. And other people said no, it's the vaccination that might have triggered a frozen shoulder. It's not only in COVID; we've seen that in other vaccinations too. So, and it's not on the injected side. So you can develop a frozen shoulder on the other side. So it's not about the injection alone. That's a possibility. Not to there is a difference with the differential diagnosis of the post-vaccine shoulders. So we got these people that are injected, well, let's say too high, more in the bursal region, and they got an irritation of the bursa, they got inflamed, and they got shoulder pain, and got stiffness, and it can look like a frozen shoulder, but in a few months it's gone. So it's also a differential diagnosis for frozen shoulder, but it can also really be the start of a frozen shoulder, maybe due to this immune response. And then, of course, finally, the post-surgery, post-operative patients that we know that are often in a sling for some period of time, and then we see a development of frozen shoulders, partially maybe due to immobilization, or due to the surgery itself, due to the induction of inflammatory process because of the surgery, or of course it already was a frozen shoulder and they got surgery for thinking it's a tendinopathy or something else, and then they continue developing the frozen shoulder and they say, oh, it's because of the surgery they developed a frozen shoulder. Maybe they already had a frozen shoulder before surgery and just didn't need that surgery that day. So that's also a possibility. So yes, we got a typical pattern of patient, and some, if you have all these comorbidities, and we see a lot of them in frozen shoulders, we see really a lot of them. If you got a frozen shoulder in your clinic, ask about this, and you will see that at least half of them will have some of these comorbidities, and you will be surprised how many of your frozen shoulder patients will have something going on outside the shoulder.
If a patient's presenting without the diagnosis of frozen shoulder, what are you mentioned it a little bit, but what are some of the differentials that we should be considering? And within that, how can we rule in or rule out some of those differentials? You already alluded to, I think, 25% loss in at least two planes of motion, this gradual onset, night pain. But what are some other things that people potentially misdiagnose as frozen shoulder, but it's something else?
Yeah, it's true. It can be confusing sometimes because there are different shoulder conditions that that also start gradual and that also give pain, give some stiffness, and well, you can think it's a frozen shoulder, and it can be something else, or vice versa. So it's important to know about this differential diagnosis. So this we've started with some rule-in criteria, but there are actually quite a lot of rule-outs also, and these are this differential diagnosis you want to kick out of your assessment to be, well, you're never sure in our job, but to be to get a high likelihood, let's say like that. So as you said, the hallmark sign of frozen shoulder is this passive external rotation loss, and that's a very important thing because many shoulder problems have pain, chronic pain. Many shoulder problems can have some stiffness, but this passive external rotation restriction is not so common in other shoulder problems. So that's a very important thing. So although many shoulder conditions have this pain, even some stiffness, not all have this passive external rotation deficit. And in general, frozen shoulders, they respond well to injections like corticosteroid injections. In general, they respond well. So if they don't respond well, that's a moment in which your likelihood of a differential diagnosis increases. If they don't respond well to a corticosteroid injection, or if they don't follow the usual pattern in which the first stage, we can talk about that later, but the first stage is a painful stage, and then they go to more stiff phase, and then the resolution. If they don't follow that pattern, that's also unusual, and then your thoughts about differential diagnosis should rise. So yeah, what are we thinking of? First of all, maybe cervical spine issues, cervical spine associated disorders, which is in fact a differential diagnosis for all shoulder problems, not only for frozen shoulder, but definitely also for frozen shoulder. Patients with cervical radiculopathy, degenerative cervical myelopathy, maybe misdiagnosed with frozen shoulder. They can have pain, shoulder pain, some active restrictions, but these patients usually they don't have restriction of passive external rotation range of motion, even not in other directions. So this passive external rotation or internal rotation is usually okay in these patients. So just screening cervical spine is essential for accurate diagnosis here. Another big group, is the osteoarthritis. So the glenohumeral osteoarthritis group is a big group. It gives stiffness, it gives pain, so it can look like a frozen shoulder. Patients are generally speaking a bit older. They're not typically 50, but more over 60, and over 60 going to 70. The average age for putting a shoulder arthroplasty is about 67. So they're typically older. They normally, well, if you just take in your assessment, if you just take plain X-ray, then you can rule out this glenohumeral osteoarthritis in most cases. So that's something we often recommend in standard assessment, getting an X-ray in these patients, for instance, to rule out osteoarthritis. And then you got patients who have a locked posterior dislocation. Having a locked posterior dislocation, but of course they should mention a trauma. Then, so normally you can rule it out in your anamnesis. They would have had a trauma. Also, again, if you had an X-ray, you could rule that out. If the X-ray is performed well, of course, if you just do a frontal X-ray, it can be misleading. But if you do an X-ray in different directions, you can rule out these locked posterior dislocations. The clinical pattern is also a bit different. And while a frozen shoulder patient, for instance, while they have this external rotation limitation from neutral, they can't perform external rotation. These patients with the locked posterior dislocation, they will have their hand on their belly. Well, they're like pushing on their belly, and they totally don't have any external rotation at all. So it's more extreme even than frozen shoulders. So that's a bit bizarre. They cannot have any external rotation. They're pushing their hand against their belly. And then there's the X-ray and the trauma. So normally you could easily rule that out. Another differential diagnostics is the big group, the rotator cuff-related shoulder pain, calcific tendinitis. This group, but they're just not characterized by this passive external rotation restriction. So normally you can take that out. Also, we don't see the typical decrease in shoulder external rotation with shoulder abduction. So what I mean with that is when you have a frozen shoulder patient and you have let's say 10 degrees of external rotation, and you perform an abduction or an elevation, their 10 degrees will even decrease up to zero when they're performing abduction or elevation. And that can be different in, for instance, rotator cuff related shoulder pain. They can even increase their mobility when they perform their external rotation mobility when they perform these abductions. So that's a big difference with frozen shoulder. Also, a way to differentiate between rotator cuff related shoulder pain and frozen shoulder is using weights. If you give your patient with a rotator cuff problem, if you give them 1 kilogram, they will have pain, for instance, also 1 on a scale of 10. But if you give them 5 kilogram, they will have 5 on a scale of 10. If you give them 10 kilogram, they will have 10. So their pain is increasing with the load you give them. While in frozen shoulders, they can say, well, I have 7 on a scale of 10, and whether you give them 1 kilogram or 5 kilogram, they're 7 or 8. It doesn't change that much when you give them more loading. So that's also something you can use in your differentiation with that group. Unfortunately, sorry, yeah.
No, go ahead. I'll ask after this.
Okay. Unfortunately, you also have some serious problems, some serious illnesses related to frozen shoulders, like shoulder region tumors, humeral bone tumors, Pancoast tumors. In this case, symptoms persist despite conservative measures, and advanced imaging may be required in this group. And your suspicion may arise if the patient is younger, for instance, if there's -40, younger, have a pain-free external rotation. That's also bizarre, and their unusual fatigue or weight loss, etc. So they're important things to rule out, not only with X-rays, because X-rays cannot always detect like these bone tumors. So it might be CT scans or something else needed to rule that out. Same for glenohumeral joint tuberculosis. It's rare, but it's a differential diagnosis. Parkinson, I mentioned it earlier. It's a differential diagnosis. We wrote a whole chapter on the relation between Parkinson and frozen shoulder because it's really fascinating. It can go both ways. So the patient can develop Parkinson and then frozen shoulder later on, or vice versa. And it's so interesting why these two are related and how they can develop from one to the other. So this really interesting pathway, which needs further research definitely to see the link between those two. And then differential diagnosis, we mentioned it, the vaccine issues. So these are the most common ones. Oh yeah, maybe not to forget the psychological issues. So patients can have restricted range of motion due to protective behaviors due to psychological issues. That's possible. So we should keep that in mind, that it can also be not really structural, but more centrally driven and psychologically driven. So multidisciplinary impact is important there, or interventions are important there, probably.
Imaging will rule out a variety of conditions or rule them in and make you have an alternative treatment plan. Does imaging need to occur to actually diagnose frozen shoulder? And if someone does have the diagnosis clinically, is there common findings on imaging that will show up consistently?
Imaging is a difficult one, and because in fact you don't need imaging to rule in frozen shoulder. There's nothing on your X-ray or on your MRI to say I can definitely see you got a frozen shoulder. Well, maybe on an MRI, but on an X-ray, no. There's nothing on an X-ray that's focusing on a frozen shoulder. So most of these imaging techniques are important for ruling out the differential diagnostics. But there is increasing knowledge about, like I said, MRI, but also ultrasound scanning. So we're trying to find some things like a thickening of the capsule or more vascularity in the capsule by using Doppler in your ultrasound. So there are techniques which we're trying to use to detect a frozen shoulder or diagnose a frozen shoulder, so really rule in a frozen shoulder. The fibrosis in the capsule, the fibrosis in the coracohumeral ligament, there's all these little things that can help us rule in. But normally it's a clinical diagnosis, so normally you shouldn't need imaging, but let's say that plain X-rays can be part of the usual assessment for ruling out osteoarthritis. I think that's an important one, and maybe some dislocations too.
Now, the patient's presenting and you're confident or highly probable that the diagnosis is frozen shoulder. They're coming in, they don't have a ton of education on what this is. As a clinician, what typically do you recommend we discuss with patients on their management options, the prognosis, the timelines? What are some things within that initial encounter that you'll start to discuss with them?
I'm glad you bring this up. Patient education is often forgotten when rehabilitation is discussed. So, and I strongly believe, and especially also in frozen shoulder, that this is really a crucial part of your patient's process to recovery. Well, we shouldn't keep in mind that living with a frozen shoulder involves uncertainty for the patient, fear, anxiety, loss of self-confidence. And these are things you should try to address in your education, in your contact with your patients. And addressing this uncertainty through patient education is, I think, really essential for positive outcomes. Informing the patient about the condition's course helps alleviating this uncertainty, this fear, anxiety. And when you decrease uncertainty, anxiety, and fear, you will immediately impact pain also. So these patients can really have a decrease in pain because of their decrease in their fear, in their anxiety. Try to address common patient concerns, such as the nature of a frozen shoulder. What is a frozen shoulder? Where does it come from? What can I do to help it for the patient itself? Or what does it mean for my job, for my hobby? These are things the patient really wants to have answered, and also some tools for the self-management. We can talk about that later. Also, I think that's interesting to explain to them what the concept of tissue irritability is, and I really believe you can explain that to patients because they can use that concept of tissue irritability for their own management. Oh yeah, and not to forget, try to be consistent between healthcare providers, because that's really something that can be of an issue. If you have different explanations for something, well, then the anxiety and the fear can get back, and then we have a problem. So that's important to get everyone on the same line when it comes to frozen shoulders. Yeah.
Probably, or one of the most common questions that patients will ask with most conditions is, how long will this take? Or when can I get back to XYZ? What is the average timeline of the prognosis or the general natural history of frozen shoulder?
Yeah, that's a good one. In many cases, we're, as a healthcare provider, we're a bit scared to answer that type of question because we're afraid that we won't be right. That's the logic thinking. And the same for frozen shoulders, but I think we can give them some ideas to think about for frozen shoulders. So on average, if you look at an average frozen shoulder patient, it's about 1.5 years up to 2 years for average frozen shoulders to go through the whole process and to be functionally okay at the end and have more or less no pain or restrictions anymore. And this average is actually, over the last decades, is increasing. So we see that while an average duration of a frozen shoulder was about 1.5 years over 10, 20 years ago, it's more or less 2 years now. It's going to 2.5, and it's getting longer and longer. And I think a lot has to do with the comorbidities. We see that people with comorbidities, like diabetes, again, their frozen shoulder will take longer. They will take longer to resolve. it will be more severe, meaning more pain, more restrictions. And we see that there is, in our society, there is an increase in type 2 diabetes, and therefore also an increase in frozen shoulders, but frozen shoulders with type 2 diabetes. So they're, by definition, the frozen shoulders will take longer with them. So if you have a patient in front of you and you know, okay, it's a year and a half up to 2 years, and you see that this patient is really obese, has diabetes type 2, has thyroid problems, then you know, okay, you can tell them it's usually 2 years, but because of your comorbidities, we must acknowledge that it might be longer, more or less 3, maybe even 4 or 5 years. If they don't have that, if they are really healthy, none of these comorbidities, they say the average is one and a half year up to 2 years. But because of the fact that you have no comorbidities at all, and this average is actually pulled up because of the amount of diabetes patients in there in the statistics, then it's possible that you will go through your frozen shoulder in less than 2 years, maybe even just 1 year, and that's also possible. So you can have some direction, but of course, explain to the patient that it's about statistics and everybody's different, and you need to be to make sure that the exceptions are possible, of course, but you can give them some guidance. And also, we see that most patients, they go through a pattern, and the clinical pattern of frozen shoulder is traditionally described in 3 phases, sometimes 4 phases. We got the freezing phase, which is mostly the painful, the inflammatory phase. Patients have a lot of pain. And you go to the frozen phase, in which the patient is getting their restrictions, and then the thawing phase, in which there is resolution. The pain is away, restrictions go away, and we know that each phase, well, let's say there is a big disagreement on how long each phase should take or can take. It's more or less like between 3 months and almost a year per phase. So there's a big difference there. But if you look at your patient and you see them going through one phase on a certain time frame, it appears to be about the same time for the other phases. So if one patient goes to the first freezing phase and it takes a year and a half to go to the freezing phase, they're not going to go to frozen and the thawing phase in a few weeks. It's going to be probably something like a year and a half each phase again. But if they go through that in just 2 or 3 months, then probably they will go through that for the next phases too. So you can somehow predict the duration of it based on these phases. But as I said, well, not all researchers love the phasing technique. It's something that's interesting, sort of the freezing, frozen, and thawing. It's very interesting for your education to the patient. But it's not always the exact situation in your patient. So it's not always a clear phasing. It can be there can be a lot of overlapping and can be difficult sometimes. And that brings us to the self-limiting thing. So it's been a long time we thought that frozen shoulders were self-limiting. They will go over, they will go away, even if you do nothing at all. And we now see that this is unfortunately not the case. Evidence is really challenging that belief that frozen shoulder is self-limiting pathology. And well, let's say only about 40% recover, even if you don't do anything at all, like no physical therapy, no injections, no surgery, nothing. Well, 40% of your patients will recover fully. But then you have like 50% that will have clinical limitations if you don't do anything.
Okay, we're back. We had a little bit of a pause. Philip was in the middle of discussing how what used to be believed that all of frozen shoulder presentations were inherently self-limiting. Philip, you're now discussing that maybe in about 40% of cases, but there's a large chunk that do not self-resolve and some type of management needs to occur. Let's take it from there.
Yeah, that's true. So we, over the last decades, we really thought that frozen shoulders were self-limiting, so they will go away just without doing something at all. But this evidence is challenging, or evidence now challenging the belief that frozen shoulders are self-limiting. So we see that only about 40% fully recover. So about 40% they recover without having any physiotherapy, injections, surgery, anything at all. They will fully recover. But that's 40%. So that leaves us 60%, in which about 50% of them will have some clinical limitations if they don't do anything. So they will really need some sort of guidance towards exercises or stretching. And then there's 10% that will have functional restrictions even up to 10 years. So that's let's say, a normal prognosis. And if your patient asks you, well, should I need physiotherapy? Then you can really be honest about it and say, okay, 40% will fully recover even if you don't do physiotherapy, and about 60% will have some limitations if you don't do anything at all. So it's up to you. You want to take that risk or not. And if you do have some limitations, it's about 10 or 20% of your range of motion that will be limited at the end. The choice is yours. But I can guarantee you they're at average 50 years of age. They have a job, they have hobbies, they all want their full range of motion. So I up to now I've never had a patient telling me, okay, I'll take my chances, and this 10-20%, it's okay, I don't need it anymore. So your patients will want your the full range of motion. This means about 40% chance that it's true if you tell your patient that they don't need anything, but it's a 60% chance that there will be a delay of interventions if you just tell them it's self-limiting. So we should put that into perspective and just clearly state to your patient what the numbers are, and they'll understand that they will need physiotherapy to get their full range of motion, to be pretty sure that they will get their full range of motion.
Let's dive into the management options. There's a variety. You mentioned early on cortisone or corticosteroids. You also briefly touched on physio. Let's start with physio interventions and management options. What does the evidence suggest throughout the course of frozen shoulder? What is beneficial and what may not be indicated or beneficial?
Yeah. So first of all, patient education. We discussed that earlier, but I think it's a main focus of physiotherapists also. I could not emphasize enough the importance of this part. Educate your patient, as we discussed earlier. Next, we have the advice, and if you can implement it in your rehab session, to be physically active. So to try to get your patients to be physically active. So this is really highly recommended, both for those patients in which local shoulder exercises are maybe too painful, but also it increases general health, it increases mood, sleep, prevents depression. Not something that should be forgotten in frozen shoulder patients. There is a big proportion that really have depressive thoughts or get into depression. So general activity is extremely important. There's also a strong link with metabolic issues with frozen shoulders. So also in this case, maybe we can have an effect on insulin levels. So try to get them physically active. Also use this exercise-induced hypoalgesia concept. By exercising, they will really get less pain. So practically, this means let them walk into the forest in the city or whatever, running if possible, cycling, whatever the patient loves to do. Tailor it to the level of irritability, as we mentioned. So this means that if your patient loves swimming, that's great. But if they're highly irritable, if they have a lot of pain, well, then that's not the most interesting thing to do first. So maybe when they're moderate or low level of irritability, but not in the early or high irritable patients. So get them to be active, get them walking into the forest or whatever they like to do. That's the first very important thing. And besides general activity, there is, of course, a place for active passive shoulder movements, which we're used to as physiotherapists or manual therapists. Of course, we need to be aware that mobilizations and stretchings may be counterproductive in the early inflammatory stage. So we need to be careful there, and think about our irritability level again. We don't want any extra pain when they're highly irritable. So when they're highly irritable, this means they have more than 7 on a scale of 10 on their pain scale. And if they're highly irritable, we don't want to provoke any extra pain. When it concerns our passive manual techniques, actually it's quite easy. There is no proven difference between any of the described manual techniques. So that there's no proven that one Mulligan technique is better than just some sliding, inferior sliding or anterior sliding or manipulation or whatever. None of these techniques have any proven benefit over the other. But they have proven to have some effect on mobility and pain levels. So that's a good thing. But you can use actually the technique you prefer for now. And then you got the active exercises. They're really emerging a lot. They can be as effective as passive techniques, and some researchers, recent studies actually, they're even saying that that the active exercises can be even more effective than the passive techniques. And it emphasizes the responsibility of the patient in the whole rehab process. So an active exercise we really mean resistance-based exercises, and they have shown improvements in pain, range of motion, function, muscle strength. So I really believe that the future is for a lot on active exercises, and we should reconsider the use of passive techniques if we can use active alternatives. Yeah, and then finally, if it comes to physiotechnical applications like cold, heat, TENS, therapeutic ultrasound, well, I'll be honest, we don't have that much evidence that they're effective at all. So it's really about patient education, general activity, passive and active exercises within their level of irritability. So the intensity is tailored on their level of irritability.
Let's transition to non-physio options. Pharmacologically, surgical, injection. You can start wherever you like, Philip, but what does the evidence suggest for best management options outside of physio?
Yeah, if we look to the pharmacological options, I think the paracetamol and NSAIDs are useful in controlling pain, especially in the first stage, of course, because then they have their pain. There is also some limited evidence from antidepressants, so that's possible. If we go towards corticosteroids, the injections are preferred above the oral corticosteroids. So the oral have some benefits, but it's very short term and it's rarely maintained. So they really go to the intraarticular administration, which is favored over the oral administration. For the corticosteroid injections, the optimal dosing is still unclear, and studies are exploring these aspects. But there is evidence that it can be beneficial in the early freezing stage. So not in the frozen or in the thawing phase, but in the early inflammatory phase. If your patient really has a lot of pain and it doesn't sleep anymore, and you need something there, then there is evidence that corticosteroid injections are optional. And then there are also other drugs like calcitonin. We talked about it earlier. Calcitonin, which is impaired in thyroid patients. We use calcitonin, or researchers use calcitonin in patients with osteoporosis, of course, because that's the logical functioning of the calcitonin. But they saw that these patients who had a frozen shoulder at the same time, they got better with their frozen shoulder. So that's the thing they're now thinking of. Well, maybe calcitonin delivered nasally could have an effect, and the first trials are really positive on that. Calcitonin has an effect on the transforming growth factor beta. It's maybe a bit technical. There are cytokines which are reduced because they're inflammatory. So in that way, calcitonin is some way anti-inflammatory. So that's probably a pathway that's interesting. It's like testosterone, by the way, which is also has an anti-inflammatory pathway, or like testosterone has an effect on this transforming growth factor beta. That's why they also think that this might be the reason why there are less men having frozen shoulder than women. Maybe it's because of these our hormones, testosterone hormones. And then there are also novel strategies, pathways like focusing on the transforming growth factor beta, gene silencing, cytokine blockades, and so on. So there's a lot of research going on new drugs, trying to get that systemic thing out of the frozen shoulder. So yeah, we talked about injections already. Surgical. There are, let's say, three options there, three main options. But I think we should keep in mind that more than 90% of our frozen shoulders do not need surgical interventions. At least 90% don't need surgical interventions, and they will do well without surgical interventions at all. So that's an important thing to start with. But those that don't react well on physical therapy, that are really having a large restriction that don't resolve, well, that might be interesting for some surgery. And then the common surgical options are hydrodistension, manipulation under anesthesia, and arthroscopic capsular release. I think these three are the main ones. Hydrodistension, and they inject fluid into the glenohumeral joint, and then it stretches and expands and then even disrupts the capsule. But to be honest, there are a few meta-analyses that have studied the hydrodistension effect, and the effects were generally small and clinically insignificant. So, well, that doesn't look good for hydrodistension, to be honest. Manipulation under anesthesia, that involves controlled manipulations to elongate or rupture the fibrous capsule, the thickened capsule, increase range of motion. But here we have a high risk of injury. So it's important to note that there are really unwanted cartilage damage, soft tissue damage, intra-articular lesions, like fractures, rare complications, fracture dislocations even. So it's a bit tricky. And also the results in the literature are unclear on the effects. Some studies show good outcomes, but others question the benefits for the risks in the manipulation under anesthesia. So that's maybe the partially the success of arthroscopic capsular release, which is done over the last few years, more and more gain a lot of more popularity. So in this case, they arthroscopically resect the glenohumeral capsule, the fibrotic glenohumeral capsule. And the advantage for that is that the surgeon has a visualization of the capsule, so it can really look at the capsule, can see which stage the capsule is. They can find the fibrosis, can also correct maybe other structural lesions. Maybe there's a torn cuff, which they can repair in the same time, or a labral lesion or whatever. So they can do something in between. Most of the research are case series, though, so this is a downside. So we don't have strong evidence yet for the arthroscopic capsular release, so we cannot make any strong statements about it, even about the effect. There was a large UK Frost trial. They found actually no clinical superiority between physical therapy, manipulation under anesthesia, and this arthroscopic capsular release. So I think for now, we should focus on our conservative interventions and get them as best as possible. And then let's say we don't need the surgical options if we get the physical therapy as good as possible. But we have the option in really difficult cases. So I think of all these options, the arthroscopic capsular release looks like the most popular for now, but yeah, on the evidence, it's difficult. I'm no surgeon, so for the best understanding of these techniques, I would need to refer to an orthopedic surgeon. But maybe that's in a nutshell what's out there and what the evidence is.
Let's go into. I don't even think I named the book Frozen Shoulder Present and Future. Let's go into what does the future of frozen shoulder research and management look like. Y'all discussed some potential future perspectives moving forward. what do those perspectives and what does that look like for research, for potential management options? What did you all find?
Yeah. Yeah, we mentioned the new pharmacological options already, but then we also have new trial interventions that are focusing, for instance, on central pain mechanisms. Our frozen shoulder patients are actually, per definition, chronic pain patients. So the focus on understanding central nervous system can influence on our musculoskeletal pain. So that's one pathway. There's a virtual reality. It's really a booming business, let's say. So it might be very interesting in frozen shoulders, where they're actually afraid of moving their arm, and then when transforming an exercise into a game, this can really be an interesting pathway. And then, of course, I think there's a big potential here, as we know that there is a great link with metabolic issues. There are now interventions looking whether they can focus, for instance, on diet in patients with frozen shoulder. Who knows? Or like a low sugar intake diet, or even plant-based diets that can have an impact. Or focusing on whole body training, aerobic exercises to lower insulin levels. And maybe we should put our frozen shoulder patients on a treadmill instead of working on the shoulder. Who knows, sir? I think we're doing a lot in that direction, working on the systemic thing around the shoulder and see whether it also has an effect on mobility, on pain levels. I'm confident that the frozen shoulder will keep me busy for a long time. So that's really interesting pathways, I think, and there are currently really trials developed and going on to see whether they can work on these things instead of, for instance, a usual manual therapy intervention, and let's see which one is effective, which is the best. I don't know yet. It's a hypothesis, of course, but we think we can do a lot with other things outside the shoulder. Yeah.
This wasn't in the outline, but I am curious, Philip, if you, over the next few weeks, realized you were developing frozen shoulder and you had to go through this yourself, this process, what are the big things you would do for yourself? Can we just kind of highlight that? And then let's say things aren't going the way you want. When would you consider, if at all, a surgical option?
Yeah, it's a good question. My first question would be: I'm too young to get a frozen shoulder. So I'm just starting at 40s, and I think, I shouldn't have got a frozen shoulder. And I would be concerned then. Actually, I would be concerned because I would think, okay, I'm 44 now. Why do I develop a frozen shoulder? How's my lifestyle? How's my diet going on? Am I doing something wrong there? And to be honest, I think we have some potential there. So that would be my first thoughts. I think if I really would start developing a frozen shoulder, I think it would be important not to panic there, and know that there is a light in the end of the tunnel. I would just hope that it will all go smooth and not that painful. But as we know the progression, as we know how the frozen shoulder develops, then you actually know, okay, maybe you're going to be having a difficult few months coming up, but don't panic. It's going to get better, and I'm going to try to improve my lifestyle, my diet, and my exercising, and try to decrease the pain that way, and to make a healthy living. I think that will be my personal focus on that. And let's hope, and never say never, but I wouldn't see myself laying on a surgeon's table for a frozen shoulder. But then again, as long as you're not a patient, it's easy to say, I will never have a corticosteroid injection, I will never have surgery. But from the moment you're a patient, maybe I say, give me that corticosteroid injection and put a knife in my capsule. Who knows? But for now, I would try to avoid that. And same for corticosteroid injections, to be honest, because we know that it might have a decreased pain effect, and that's great, but it also has a downside on a long term, and it's not the best for your insulin levels to this corticosteroid. So if I could avoid that too, I would. But again, when I have 9 on a scale of 10 and I'm not sleeping anymore, I might take 2. Yeah.
That all makes sense. Anything else that you feel like we didn't touch on, or any major misconceptions or things you want to touch on before we wrap it up, Philip?
Well, we discussed a lot already, but maybe I do want to take the opportunity to emphasize something else. I've talked about it a little bit earlier, but the impact of frozen shoulder, of course, varies among individuals, and we may not forget that a frozen shoulder also leads to sleep problems, cognitive functional issues, emotional well-being problems, and social issues. Social engagement is reduced, domestic occupational activities are reduced. And as I told earlier, these patients can develop frustration, fear, low mood. Many patients report anxiety, depression, and even consideration of suicide is reported in some cases. So this is really important. And uh, things like delayed diagnosis, lack of awareness, inadequate empathy from healthcare professionals, like, oh, it'll go away in 2 years. Don't bother me with your nagging about your shoulder. These are really problematic and can contribute to the patient's challenges. So my last advice would be go for a strong therapeutic relationship with your patient, understanding the patient's struggles and addressing their psychological impacts. Have some empathy, and listen to your patient, and that's really listen to the patient. I think that might be very important for your patient with a frozen shoulder.
I think that's a great place to stop. We will link the book in the show notes for people who want to dive more into this topic. There's also a 30% discount code that you were nice enough to send over. And I think we'll call it there. Any other final thoughts, Philip?
No, perfect. Thanks, Chris, for having me. It's really been great here. I'm happy to share some think about frozen shoulder. Thanks.
Yes, thanks again. Bye.